Greetings from SAFOG. I welcome you all to the SAFOG webinar organized by Maternal and Perinatal Health Committee on saving mothers and babies, learning from large multicentric studies. We are lucky to have a panel of panel of experts from all over the region, and I welcome you all to this webinar. So let me introduce to you to the Committee of Maternal and Perinatal Health Committee. The chairperson is Professor Sadiah S. Paul, while the co-chairperson is Dr. Preeti Kumar, and we have members from all over the region, including Professor Shama Muneem, Dr. Darshana, Dr. Snigdha, Professor Latif Shamsuddin, and Dr. Sheela, and I'm the coordinator. So I am Dr. Mariam Iqbal, Head of Department at Integrated Medical Care Hospital, Lahore, of the Department of OBGYN, and Regional Technical Consultant, Punjab, for National Committee for Maternal and Neonatal Health. I have the pleasure of introducing Professor Sadiah S. Paul, who is the chairperson of Maternal and Fetal Health Committee, SAFOG. She is also the chair of Academic Board and ex-vice president, Society of Obs and Gynaecology, Pakistan. So I'll request Dr. Sadiah S. Paul to take over, and as she's the coordinator for the rest of the webinar. Over to you, Dr. Sadiah.
Thank you, Dr. Mariam, for your kind introduction. Professor Yousaf Latif, who is the Secretary General, could not join us today as he's traveling, but he sends his best wishes to us for this webinar. I would first like to introduce who needs no introduction actually, Sir Arul Kumaran, who is an external advisor to SAFOG. That's a special position he holds with us. He's Professor Emeritus of Obs and Gynae at St. George's Hospital, London, University Hospital, Professor and Head of Department of Obs and Gynae at St. George's since 2001 to 2013. He's the Foundation Professor of Obs and Gynae at University of Nicosia, Visiting Professor, Institute of Global Health Policy Innovation, Imperial College London, past President of FIGO, the British Medical Association, the Royal College of Obstetricians and Gynaecologists of the UK. He was appointed Knight Bachelor by Her Majesty the Queen of UK in her birthday honours list in 2009 in recognition of his services to medicine and healthcare. So today we are also joined by the founder president of SAFOG, Professor Rashid Latif Khan, who is Professor Emeritus Obs and Gynae, pioneer of the ART program in the region and established the first IVF center of Pakistan. He is very famous and well known, and we are very pleased he joined us. We will also be joined by Professor T.A. Chowdhury from Bangladesh. He is the past president of SAFOG, Professor of Obs and Gynae, Bangladesh Institute of Research in Diabetes, Metabolic and Endocrine Diseases, Dhaka, Bangladesh. He's also the president of Fertility and Sterility Society of Bangladesh, amongst other laurels. Professor Ganesh Dangal from Nepal is the academic director, senior consultant, researcher, and professor of Obs and Gynae at Kathmandu Model Hospital under National Academy of Medical Sciences. He's also the editor-in-chief of Journal of the Nepal Health Research Council, Kathmandu, Nepal. We're very happy that he has joined us today. Professor Farrukh Zaman is also a past president of SAFOG. He's professor of Obs and Gynae and former principal of Postgraduate Medical Institute of Lahore, member of the Council of CPSP, member of the past president of Society of Obs and Gynae of Pakistan, member of the executive board of FIGO since from 2006 to 2009, chair of Audit and Finance Committee of FIGO from 2009 to 12, and principal of Rashid Latif Medical College. And currently he's a consultant at Hamid Latif Hospital, Lahore. We also joined by Professor Shyam Desai, who is the president-elect of SAFOG. He's professor of Obs and Gynae at Mumbai University for 30 years, president of FOGC in 2005, served as office bearer of SAFOG for 23 years, founder and deputy secretary general of SAFOG. So at present, I already mentioned he is the president-elect. So we're also joined by Professor Sheela Mane, who is at present DNB Professor, KC General Hospital, Bengaluru. She's a senior consultant at the nursing home at Bangalore. She's also a member of the Maternal and Perinatal Health Committee of SAFOG and has many laurels to her name. Professor Rohana will be giving his message very shortly. He's our president. Our speakers include Professor Luman Sheikh. She is an endowed Puribai Kanji Jamal Professor and Chairperson, Department of Obs and Gynae at the Ahsan University Hospital in Pakistan. She's a fellow of the Royal College of Obstetricians and Gynecologists, a fellow of the College of Physicians and Surgeons of Pakistan, first internationally certified maternal medicine consultant in Pakistan. And she strongly believes in collaborations beyond borders, and she will be speaking about the emotive trial today. Professor Ian Roberts is a professor of epidemiology at the London School of Hygiene and Tropical Medicine. He trained as a pediatrician in the UK and then in epidemiology at the University of Auckland and McGill University, a clinical academic who works collaboratively with health professionals worldwide to conduct large multi-center clinical trials aimed at improving patient outcomes in life-threatening emergencies. He works with others to build global research partnerships to answer questions together that could not be answered by anyone working alone. He has played lead roles in several large trials, including the CRASH trials and the WOMAN trial, and he'll be speaking about the WOMAN 1 trial today. Professor Sudhin Thayil is a professor of perinatal neuroscience in Imperial College London. He's an international authority on neonatal encephalopathy and is the director of Center for Perinatal Neuroscience at Imperial College London. NIHR Clinician Scientist Fellowship and NIHR Advanced Fellowship. He has conducted some of the largest studies in the world on post-mortem magnetic resonance imaging, magnetic resonance biomarkers in neonatal encephalopathy, and on evaluation of hypothermia treatment in low and middle income countries that has had a direct impact on clinical practice. And he has over 100 publications. So we are very honored that he has joined us today and will be speaking on his study, a multi-center trial. Dr. Rupsa Banerjee will be also a co-speaker in that session. She's Assistant Professor, International Institute of Health Management Research, public health professional with diverse experience in medical education, research, health system strengthening, and capacity building. So she will be also speaking about the data monitoring aspect of the trial. And I'm also grateful to Professor Farhana Diwan from Bangladesh, who is the Deputy Secretary General of SAFOG and President-elect of OGSB. She's Head of Department of Obs and Gynae, Ibn Sina Medical College, and Deputy National Coordinator, FIGO PPIUCD Project, Bangladesh. So she will be giving the vote of thanks in the end. Thank you very much. I would like to start this webinar with a message requested from our president, Professor Rohana Haththotuwa. He is also the founder, chairman, Nine Wells Care Mother and Baby Hospital, Colombo, Secretary General of Asia Oceania Federation of Obstetrics and Gynaecology, immediate past chairman, Menstrual Disorders Committee, FIGO, President, South Asia Federation of Menopause Societies, President, World Gestosis Organization, past President, Sri Lanka College of Obstetricians and Gynecologists, past President, Menopause Society of Sri Lanka, and Treasurer of Asia Pacific Society for Infections in Gynecology and Obstetrics. Welcome, sir.
Right. Okay, 1 minute. Yes, thank you very much, Professor Sadiah, for that very kind introduction. I'm very happy to be associated with this webinar on saving mothers and babies, learning from large multi-center studies, and which has been organized by the Maternal and Perinatal Health Committee of SAFOG. So I thank Professor Sadiah, Ahsan, Chair, Maternal and Perinatal Committee for organizing this webinar, very informative webinar on the proposal made by Professor Sir Sabaratnam Arulkumuran. Professor Sadiah and Professor Preeti Kumar, who is the co-chairperson of this Maternal and Perinatal Health Committee of SAFOG, have been very, very active and have been organizing and conducting many webinars and training workshops during the last few months, and particularly training doctors and health workers in the management of postpartum hemorrhage. And they have conducted workshops in Nepal too. It's face-to-face workshop. So I'm thankful to this committee headed by Professor Sadiah and co-chaired by Dr. Preeti Kumar for all their great work. Now I am thankful to Professor Sabaratnam Arulkumuran. As you know, he has been sharing so many multi-center studies which have been completed successfully, and also there are still more studies ongoing. He for recommending this program to the Maternal and Perinatal Health Committee and for initiating this webinar. Also for advising on the topics and for introducing the speakers for the webinar, which has made the webinar more attractive. So the multi-center studies have not been conducted much in our SAFOG countries, and the knowledge and experience on these studies is low among most of our members. So this program, I'm certain, will be very helpful and educative to us, and will encourage many of us to do multi-center studies and also to participate in them. As we all know, multi-center studies are clinical trials which are conducted following a single protocol, but conducted in more than one place, and consequently by more than one investigator. So planning a multi-center clinical trial is a long and arduous task that requires substantial preparation time. So for the success of a multi-center studies, most important are the recruitment centers, investigators who are dedicated, cooperative, and selfless in the team effort to achieve the goals that cannot be reached by a single center effort. So there are many benefits of multi-center trials, which include larger number of participants, different geographic locations, the possibility of inclusion of wider range of population groups, and the ability to compare results among the centers. At the same time, multi-center studies faces many challenges and problems. So we are very fortunate today that we are able to listen and learn from experts who have been leaders in several of these multi-center studies. So it is said that we all know that we have to learn from the problems and mistakes of others. So we will not live that long to learn everything from our mistakes. So we are privileged to have as speakers Professor Luman Sheikh from Emotive Study, Professor Ian Roberts from the Women's Study, Professor Sudin Tayal from the PREVENT study, and Dr. Rupsa Banerjee. They will be talking on designing and implementing large multicenter studies, difficulties encountered in conducting them, and how to improve the outcome by external quality audits. So this will be very, very informative to us. And I must also say that the presence of our honored guest, Professor Rashid Latif Khan, whom we all respect and honor, the founder president of SAFOG, he has been the live wire behind the success of this federation. So I'm very thankful to Professor Rashid Latif Khan. At the same time, Professor T.A. Chowdhury, I think he may join later. He is also from Bangladesh, who have been supporting us with almost all the programs. And we have Professor Ganesh Dangal, who is the chairman of the research committee, and for his presence. Also, the presence of past President Professor Farrukh Zaman. He is also one of the guiding force for us in this SAFOG. He has been very, very supportive of our activities and has been advising and guiding us in so many ways. And also have executive board members, Professor Shan Desai, who is the president-elect, and Professor Yousaf and Professor Farrukh, our secretaries. So I thank all these executive board members for their presence and for the support they are giving with our programs. So without taking any more time, I will hand back to Professor Sadiah to continue with this program. I know which will be very helpful to all of us. Thank you very much for giving me this opportunity. Thank you.
Thank you, Professor Rohana, for your kind message. We will now proceed with our program. We will proceed with the webinar now. And I will invite the first speaker, Professor Luman Sheikh, to talk about the emotive study, designing and implementing a large multi-center study.
I am going to share a brief overview about the emotive study, focusing on the rationale for the study, the trial design and progress to date. Postpartum hemorrhage is the leading cause of maternal death worldwide, especially in low-resource countries. The tragedy is that these deaths are preventable and they have been eliminated from many countries. Our goal is to see these eliminated from all countries. PPH remains common despite having evidence-based preventive strategies. The CHAMPION study, a largest study ever done in PPH in 10 countries, compared top-quality oxytocin to heat-stable carbetocin. In this study, it was found that both the uterotonic drugs are equally good in preventing PPH. However, another interesting result was that still 1 in 8 women had PPH. A woman suffering from PPH is 100 times more at risk of dying or suffering severe complications compared to a woman that did not have a PPH. Even if we replace oxytocin with heat-stable carbetocin, we still cannot risk losing 1 in 8 mothers. Question remains, what else can be done? Considering this as a public health priority, WHO issued recommendations for prevention and treatment of PPH in 2012. There are still challenges in implementation of the guidance. WHO recommends uterotonics such as oxytocin, carbetocin, misoprostol, etc. as the mainstay of prevention and treatment. Use of isotonic crystalloids is recommended in preference to colloids for initial fluid resuscitation of women with PPH. Uterine massage is another treatment which has been recommended. However, in clinical practice, implementation of these recommendations is variable. Uterotonics are used consistently, but often administration is delayed. Use of crystalloids and uterine massage is inconsistent. There is a lack of clarity about what uterine massage is and how it should be used for the treatment of PPH. In addition, we all know the woman trial finding that tranexamic acid could save 1 in 3 women from PPH and WHO now recommends tranexamic acid for all women with PPH irrespective of the cause. Has this happened though? WHO recommends these interventions as a first response bundle to promote a more consistent approach by healthcare providers in delivering all the interventions at same time or in quick succession. If we talk about challenges, one of the major challenges is late detection of PPH. Hence, the recommended interventions are also delayed, which means they are less likely to work. The data from the CHAMPION trial confirms that early detection of PPH is a major challenge. If you see this graph, horizontal axis represents blood loss by increments of 100 ml and vertical axis represents percentage of women who received treatment for PPH. Most women did not receive treatment when they have PPH of 500 ml. And even with 1 liter blood loss, 30% of women did not receive a treatment uterotonic. This trial used a drape to collect all the blood and was weighed afterwards, so the blood loss measurements were accurate. In usual practice, doctors and midwives visually estimate the blood loss, which is highly inaccurate and is usually an underestimation. We need to find a way to detect PPH early. The situation in real life is perhaps worse. In Nigeria, typically it is reported that only 1 in 100 women had PPH according to the routine practice data. In the CHAMPION study, they treated almost 10% of women, so the drape most probably has changed behaviors, resulting in more women being diagnosed with PPH and receiving treatment. In the E-motive study, we want to find out if we can improve even more and ensure that no woman with PPH is missed. Another challenge is delayed or inconsistent use of interventions for managing PPH. Many a times, these interventions are delivered in a sequential manner, that is like waiting after uterine massage and or oxytocin to see if this works. If not, then moving to another intervention such as tranexamic acid and so on. If bleeding stops, this approach appears acceptable. However, for cases where bleeding continues, we need to be conscious that there was a missed opportunity when all the effective interventions could have been given earlier as per WHO recommendations. For example, giving tranexamic acid at the same time with oxytocin with better chances for women to stop bleeding. Remember that once clotting gets deranged, tranexamic acid will not work. Our hypothesis is that if providers were to diagnose PPH early and treat it using the WHO first response bundle, they would be more likely to stop the PPH and deaths, and complications from PPH will be substantially reduced. Even though the WHO bundle can improve adherence to guidelines, our formative work has identified several barriers to implementation of care bundles, including limited staffing, lack of knowledge and skills, lack of self-efficacy, fear of reprisals for poor compliance, lack of awareness and engagement, regulatory barriers that prevent task sharing. Enabling factors identified include perceived sustainability, supportive leadership, adequate resources, training, teamwork, communication, and simplified record keeping. We have designed an implementation strategy to address barriers and enablers for improving bundle implementation based on first response trolleys or carry cases, audit dashboards, bundle champions, and on-site simulation-based training. Our hypothesis is that early detection of PPH and rapid implementation of motive PPH bundle as a first response will reduce severe PPH, need for life-saving surgery, and deaths from PPH. However, a trial is needed to demonstrate that this strategy is effective and cost-effective. E-motive study will generate necessary evidence for healthcare practitioners and policymakers to implement and scale up this program with confidence. So what is the E-motive intervention? The first E is the early detection strategy. Early detection can include usual methods of assessment such as visual assessment of blood loss, maternal condition, and vitals. But this will be enhanced by a safety net the use of a calibrated grape with a bundle trigger action threshold at 500 ml of blood loss. As mentioned earlier, analysis of Champion data showed that the use of a calibrated grape could increase PPH detection rate from 1.8% to 10.4%. Safety trigger threshold at 500 ml blood loss will capture 93.8% of serious outcomes such as major morbidity or death from all causes and all deaths from PPH. The grape is already used in Vietnam and parts of India routinely. It is fairly cheap, and we do hope that reusable options will soon be available. WHO has carried out a technical consultation to design the first response bundle and has achieved wider consensus on its components. They are partnering with us to co-lead further development of the implementation strategy in this large effectiveness trial. For implementing a new approach in diagnosis and treatment of PPH, all doctors and midwives in eMotive need to be trained. We needed someone who has experience in delivery training packages in Africa and Asia and has the people on the ground to do it. So we have partnered with FIGO. FIGO will deliver the training package to health facilities, adapt their materials and training to accommodate the eMotive for use in each country. Talking about implementation science, we know that changing what people do is never easy. There is a need to go deep into the science about what would it take to change behaviors and adopt the early detection strategy and the bundle. So we partnered with the UCL Center for Behavior Change. The studies run through the WHO Collaborating Center for Global Women's Health at University of Birmingham and Birmingham Clinical Trials Unit. Talking about the trial design, eMotive is a cluster randomized trial. Hospitals are randomized and not the patients. Selected hospitals have 1,000 to 5,000 births a year, provide comprehensive obstetric care, including the ability to perform a surgery for PPH. They have been selected to be geographically and administratively distinct from each other. Sites that have already implemented components of our proposed intervention are excluded. The intervention we propose is focused on early detection of PPH, a first response that is based on WHO recommendations. Implementation strategy includes simulation-based training and other methods to ensure successful implementation of the new protocol, and this will be compared to the usual clinical care. Our primary outcome is a composite outcome with reduction of 25% of severe PPH, postpartum laparotomy for bleeding, or postpartum maternal death from bleeding. Key secondary outcomes are detection rate and compliance with WHO first response bundle. However, we are also collecting a whole host of secondary clinical and resource outcomes. As you can see, hospitals are spread almost everywhere in the countries, and there are 86 hospitals in Kenya, Tanzania, Nigeria, South Africa and Pakistan involving over 215,000 women. This study begins with a baseline period of 7 months when there will be no difference in how PPH is detected and managed. In these first 7 months, outcomes from all vaginal births in the hospitals will be collected while we are measuring the blood loss accurately. At the same time, in different hospitals, we will perform surveys, interviews and workshops to define the protocol and test the eMotive intervention to ensure it works as expected. At the end of 7 months, 86 hospitals are randomized, whereby 43 will use the new protocol and the other 43 will continue usual care. We will take 2 months to train all sites, and then for another 7 months, data will be collected from the intervention phase to investigate if the new protocol has improved outcomes or not. The eMotive study is fully operational and is acquiring pre-randomization baseline data from selected hospitals. While the eMotive trial is progressing with baseline data collection, we are refining the intervention through adaptive cycles which implement and test the intervention and the implementation strategy in 3 hospitals in each country. A study to report results by September 2023 on over 215,000 women. So this is all about the eMotive trial, and I'll be happy to answer any questions.
And now our next speaker is Professor Ian Roberts from UK, who will be speaking on the Woman One study.
Thank you for asking me to talk about the Woman trial. I will share my screen, and I think you can see my slides. The story of tranexamic acid and the Woman multicenter trial began with this woman. This is Utako Okamoto. She was working in the 1950s to develop a treatment for postpartum hemorrhage. They knew that when women are bleeding, the body responds by trying to find a fibrin blood clot, as shown here, this yellow stuff. But they also knew there was an enzyme in the blood called plasmin that breaks down this fibrin clot, and they hoped to find a drug that inhibited this breaking down of the fibrin, this fibrinolysis. And they invented a drug called tranexamic acid, which was dramatically effective. Tranexamic acid is often known as TXA nowadays. And over the years, trials in surgery showed it significantly reduces surgical bleeding. Tranexamic acid cuts major surgical bleeding by about a quarter. It reduces blood transfusion by about a third, and this is whatever the type of surgery, and there's no increase in thromboembolic events. In fact, recently there was a very large trial reported in the New England Medical Journal. This is a couple of months ago. 10,000 patients, 5,000 got tranexamic acid, 5,000 got placebo, near enough. Tranexamic acid cut the risk of bad bleeding from 12% to 9%, highly significant, but there was no increase in vascular occlusive events. So this is a really important treatment that has been discovered. Now, this is relevant to postpartum hemorrhage and women in lower middle income countries because there's a huge blood shortage in many low income countries. We know that women with even if they have quite severe postpartum bleeding, they often only get 1 or 2 units of blood, often much less than they need. And that's because of this blood shortage. So if tranexamic acid was more widely used in surgery, there would be more blood available for the treatment of postpartum hemorrhage. We did an economic evaluation of this many years ago. But this, when we did it, the evidence for the reduction in blood loss in surgery was not as strong as it is now. So we're even more sure about this now. Tranexamic acid used in surgery would save blood for use in other life-threatening situations like postpartum hemorrhage. And also, because of the risk of transfusion-associated infection, it would reduce the risk of HIV and hepatitis B and C. Another large multi-center trial of tranexamic acid was tranexamic acid in the CRASH 2 trial of tranexamic acid in trauma patients. Highly significant reduction in death due to bleeding and all-cause mortality, and once again, no increase in vascular occlusive events. And these data would save lives all around the world in high, middle, and low-income countries, particularly big countries like India and China, but also the USA and Brazil, where gun violence is very common. But huge mortality reductions. This is also relevant to pregnant women because I came across this very shocking study a few months ago that actually homicide is the leading cause of death in pregnancy in the postpartum period in the US. much more important, way ahead of postpartum hemorrhage, hypertensive disorders. So, if we use more tranexamic acid in trauma, then pregnant women will also benefit. Now, the one you asked me to talk about is the woman trial, this large multi-center trial. It was conducted in several hundred hospitals in over 20 countries, and it was a huge international collaboration. So the idea is that by working together, we can do things that nobody could have done on their own. And I'm glad that you're focusing this webinar on multi-center trials, because I think they've got a huge potential to improve outcomes for women. So the woman trial, 20,000 women were randomly allocated to get a gram of tranexamic acid by intravenous injection or matching placebo. 10,000 got tranexamic acid, 10,000 got placebo, and we got this great result. First of all, we know that women died really soon after bleeding onset, but there was a statistically significant reduction in death due to bleeding with tranexamic acid, about a 20% reduction in death due to bleeding, bigger than a 20% reduction if you consider the women who got it early. There was a highly significant reduction in the risk of laparotomy for bleeding. So if you give tranexamic acid at, say, postpartum hemorrhage after vaginal delivery or cesarean section, you're less likely to have to operate or reoperate in the case of cesarean section. Much less likely. And it's almost certainly because it reduces this coagulopathic bleeding that can go on and force you to go back in. There was no increase in vascular occlusive events. The other thing that we know, because this individual patient data meta-analysis included tens of thousands of patients, because we've got a lot of data, we can actually not just look at crude results like was it given within 3 hours or after 3 hours, but we can look at it continuously over time. And we see that the survival advantage on the y-axis is much greater if you give it early. So it needs to be given as soon as possible. And actually there's a 10% reduction in the survival advantage for every 15 minutes treatment delay. Now we're trying to find ways to extend the use of tranexamic acid to women who deliver out of hospital. So, this woman delivering here with a midwife or traditional birth attendant, she can do a lot of things, but she probably can't give intravenous drugs. But we've discovered that tranexamic acid is rapidly absorbed and well tolerated after intramuscular injection. So that has the potential to take tranexamic acid out of the hospital into the community where more women can benefit. So we've done lots of pharmacokinetic studies. We've done studies in pregnant women and healthy volunteers, trauma patients who are shocked, and it's very rapidly absorbed, even in shocked patients. In fact, in shocked patients, you get higher levels because tranexamic acid doesn't seem to have much of an shock doesn't seem to have much effect on muscle absorption, but does reduce renal elimination. So you get actually higher levels. So it's really good news. So to summarize the main results of the woman trial, it reduces postpartum hemorrhage deaths. And it's the only drug that's ever been shown to reduce postpartum hemorrhage deaths in a randomized trial. It's effective regardless of the cause of postpartum hemorrhage. Now, oxytocin, in the woman trial, among women who died of postpartum hemorrhage, about half of them were due to atony. Half of them were due to other causes. Now, tranexamic acid, the good news is it's effective regardless of the cause of bleeding because it acts on the bleeding. It reduces the bleeding, whatever the cause. That's unlike oxytocin, which is only effective for those postpartum hemorrhages where uterine atony is the problem. And that's another good reason why you shouldn't wait to see if uterotonics have made a difference before giving tranexamic acid, because that's just causing unnecessary delay. And in any case, it's not going to work in half of the patients because they have a different cause. So it should be, as per the WHO recommendations, be given as soon as possible after PPH onset. Tranexamic acid is heat stable, unlike oxytocin, and it's inexpensive. It also reduces the need for reoperation due to bleeding, and there's no increase in adverse events. The next important multi-center trial, I mean, there might be others, but the next one we're involved in is the Woman 2 trial. This is tranexamic acid for the prevention of postpartum bleeding in women with anemia. So anemia is a strong risk factor for postpartum hemorrhage. Anemic, thin blood bleeds more quickly, and anemia is a strong risk factor for death should postpartum hemorrhage occur. And so we're trying to treat women with moderate and severe anemia before they have postpartum hemorrhage, in the hope that we can prevent it. And I hope we will have results before too long. We've randomized about 9,000 women from hospitals all around the world. And I think, we're looking forward to this result. So thank you very much for listening. And I'm glad you're interested in multi-center trials. I think they're hugely important. Thank you.
Thank you, Professor Ian Roberts, for a wonderful presentation. I hope you will stay with us because we will be having a question and answer session. Also, I will request people who are participating in this webinar, they can please type their questions in the Q&A chat box. So in the meantime, now I would like to introduce our third speaker, which is Professor Sudhin. I will now request him to give his presentation. Thank you, Professor Sudhin.
Repeat. I'm an academic neonatologist, now talking about epilepsy to obstetricians. So you might be wondering why. Let me tell you what is the role of obstetricians in epilepsy. So worldwide, there are around 60 million people with epilepsy. That's the whole of the population of the UK. And around 12 million of this live in India. So 1/6 of the burden is in India. And I'm pretty certain the remaining will be in Pakistan, Africa, Nepal, and so on. So it's a huge issue for developing countries. And in India, we have around 0.5 million or 5 lakh new cases occurring every year. And about 17% of these is due to birth-related brain injury, or I'm just going to call it as neonatal encephalopathy or hypoxic ischemic encephalopathy, interchangeably for the purpose of this talk. So about 17% is due to something happening around the time of labor, which causes a brain injury, and then these babies go on to develop epilepsy. So this is a preventable cause of epilepsy. This is something obstetricians can do to prevent epilepsy. Epilepsy occurs, it's a lifelong disease. There is nothing much you can do. Of course, you've got good treatments, but it's chronic and lifelong disease. And if we talk about birth asphyxia or neonatal encephalopathy or HIE, like I said, I'm just going to use it interchangeably. Most 95% of the burden occurs in low and middle income countries, the areas in red in this map. Now, we used to think the HIE in high income countries is same as in LMICs, just the numbers are higher. But increasingly, the data shows that's not the case. What we say is HIE in high income countries, it typically occurs during an acute, something suddenly goes wrong during intrapartum period. Either it is massive bleeding, abruption or something. We heard about bleeding PPH now, but you can have antepartum bleeding, abruption, cord collapse, and so on. That causes an acute injury or acute insult to the fetal brain. But the fetus is healthy prior to this And then you get something called a primary energy failure and a secondary energy failure. And in those babies, what we normally do when these babies are born in the UK or US, we cool them for 3 days, and that improves their outcomes. Now, this situation is very different in LMIC settings, because the brain injury in these settings is not happening because of a single acute intrapartum event. It's happening because the brain is already compromised from a variety of factors, including growth restriction, malnutrition, infection, and so on. So you don't actually need a single acute event to cause the brain injury. Just the normal hypoxia of the labor process or excess use of oxytocin can cause brain injury in these babies. And in these settings, schooling is not effective. And let me tell you the reason why I say this, because even in the UK, when we have a baby with severe HIE, there is eye rolling of neonatologists when they talk to obstetricians, and there is always a big problem. But I can tell you, the HIE that is happening in LMIC is not the fault of these babies are already compromised, and what we are hypothesizing as a weak baby in the womb, which is causing this brain injury. So when we looked at the gene expression studies in these babies in high-income countries and LMICs, they're very different. The mechanism shows an acute injury in high-income countries and much more intermittent or subacute injury in LMICs. Now, and this is what we're going to call as the weak baby in the womb. So this baby is already compromised, brain is already compromised, and a little bit of hypoxia can cause a catastrophic brain injury. Now, that is sad, because these are the babies who need much more closer monitoring than healthy babies in high-income countries who suddenly have an acute event. Classical case of the inverse care law. So because we don't have one-to-one monitoring in labor rooms in LMICs, and precisely that's the place you need that, because these babies can very easily get brain injury during labor. So then we started thinking, what can we do? Of course, we cannot have one-to-one care in labor rooms in LMIC. That's just not realistic, not generalizable. So then we looked at what are the evidence-based interventions that can improve intrapartum care and are generalizable. And we came up with 4 main things, 3 intrapartum interventions or elements of this particular care bundle. And surprisingly, one of the most evidence-based and one of the most simplest one was just a trained constant birth companion. A lot of good randomized controlled trials, Cochrane review shows that if you have constant birth companion during labor, that improves labor outcomes and improves condition of baby at birth. But surprisingly, it's still not used widely around the world, especially in LMICs. And the second one was this partogram. So partogram, as you know, has been always in the WHO guidelines for many decades, and has been always the paper partogram has been always supported by these guidelines. But in reality, we all know nobody has got the time to fill the partograms in real time. So often it is filled in retrospectively, which defeats the purpose. So the second care bundle we are using is an electronic partogram using a tablet computer bedside. So your data entry is in real time. You cannot do it retrospectively. And there are some alerts and prompts which guides the clinician as well. And the third one is fetal monitoring. Again, we know continuous fetal monitoring using CTG is neither feasible nor recommended anywhere, even in high countries, although especially in the US, often women are strapped to this continuous CTG monitoring even when they are low risk, which reduces mobility and increases the obstetric outcomes. So continuous monitoring is not something we would recommend for low risk women. So what we are doing this in the PREVENT study is intelligent intermittent auscultation as described by Prof. Arul Kumaran some time back. So instead of just listening to the heart rate, fetal heart rate, we are looking at the trace of the fetal heart rate in this graph in a graphical way. And you are just not looking at the number, you're looking at the acceleration and decelerations. So these are the 3 key intrapartum elements. And the fourth one is, once baby is born, you need to give a good basic resuscitation, early cord clamping, and avoiding hyperthermia. We should not be cooling these babies because cooling in these settings will cause more harm. So avoidance of hyperthermia is vital. So this is the design of the PREVENT study. We are recruiting 60,000 women from 3 big hospitals in South India. In the first year, we are collecting the baseline data on these outcomes. And the second year, we are introducing the care bundle, which involves these 4 elements, which I mentioned. And our outcomes are both short-term, looking at moderate or severe neonatal encephalopathy, brain injury, etc. And then long-term is neurodevelopmental outcomes at 18 months and epilepsy at 18 months. So this is the design of the PREVENT study. Now, when we heard about randomized control trials, how elegantly the women trial could show the effectiveness of Tranexamic Acid. But when you do an before and after study or interrupted time series study, there is a lot of confounding factors that comes in we need to account for. So one of the things we are doing in the PREVENT study is an external process evaluation or audit to examine the fidelity of each of these elements. And this is what Dr. Rupsa Banerjee from IHMR is now going to talk about. So this is a large team, against large multi-center study. A lot of people from around the world are involved. Prof. Arul Kumaran again is chairing the steering committee of this trial. And thank you so much to all of you for listening. I'll now pass on to Rupsa for the second part of the talk.
Thank you, Dr. Sudhin. The second part of your presentation is going to be given by Dr. Rupsa Banerjee. Professor Rupsa, please carry on with your presentation.
Thank you so much, Professor Sadiah, for that kind introduction. I am just going to share my slides. I hope it's visible. All right. So good evening, everyone. And I'm very happy to be here. And I thank the organizers for having me here in this forum. I'll be talking about about how to improve research outcomes by external quality audits and focusing specifically from the PREVENT study. Just a background, so IHMR Delhi is a collaborator in the PREVENT study. And as an institute, we are engaged in research relevant to health policies and programs. And as a collaborating institute, we were entrusted with the responsibility of carrying out the quality monitoring and process evaluation of the PREVENT study. And I will just talk briefly about the learnings from this audit. So like we have heard from Professor Sudhin, so PREVENT study is being implemented in 2 phases. So a baseline data collection phase, which started around July 2020, following which in the last part of the baseline data collection phase, the care bundle, which consists of the 4 components, was piloted in all the sites. And after the piloting, the actual implementation of the care bundle began in March 2022. So we conducted a quality audit during the care bundle pilot initially, so that the findings from this audit could guide the study teams in refining each of the care bundles. And following which, after the implementation of the care bundle, we conducted another quality audit to look at the status of the care bundle implementation. Now, the external quality audit was basically what we aimed at was to study the fidelity, to study the extent to which the activities under the study, focusing specifically on the care bundle implementation, was happening as per the study protocol. Along with this, we also wanted to look at the data capturing process and the data validity. Thirdly, the PREVENT study being a pragmatic study, we also wanted to understand the participation of the study sites in adopting the care bundle intervention. We also wanted to explore any challenges which the study sites faced with respect to resource availability and with respect to the aspects of implementation of the care bundle. And following the first audit, the findings were shared with all the sites. And the second audit, we wanted to find out whether the recommendations were adopted and how the care bundle implementation was being carried out in the intervention phase of the study. Now, while designing the quality audit, we adopted a mixed methods approach, which mainly looked at, which we adopted were qualitative data collection methods, supplemented by quantitative assessments. And we made sure that we included all relevant stakeholders in order to find out the fidelity, not only from the service provider's point of view, but also from the end user's point of view. At the outset, we framed indicators with, in consultation with the experts, subject matter experts who were involved in designing the care bundle interventions. And these indicators focused on all aspects of the implementation of each care bundle. Everything that we have tried to talk about in the study protocol, and how each and every care bundle is going to be implemented right from the start till the end. Also, along with this, we defined certain standards for threshold beyond which we would alert the study sites, and also any deviation from protocol would be investigated and rectified. Then we defined the means of verification, and this was particularly an important process because to identify what would be the best source of data that we could get, and whether it would be more appropriate to use a qualitative approach versus a quantitative. And in most cases, we used a combination of both and triangulated the data. And also the audit and the indicators were designed in a manner so that actionable feedback could be given to the study sites so that they could act upon them to refine the study. This is a little bit in brief about the indicators. It is not exhaustive. There were a total of over 50 indicators, but this is broadly looking at the domains which we wanted to explore. So the first bundle, which is the birth companion. So here we wanted to see how the pregnant women and their attendants were being oriented to the concept of birth companionship, and how the birth companions were being trained regarding their role during labor. So we adopted a qualitative approach for this. We interviewed the mothers, we interviewed their attendants, and especially the mothers who were beyond 8 months of gestation and were getting ready for birth. Along with this, we also wanted to observe directly the implementation of the particular bundle. We also wanted to assess how many women actually had a birth companion present during all the stages of labor, for which we adopted a direct observation approach in the labor rooms, and also how the birth companions, to what extent rather, the birth companions were adhering to their role, starting from admission till post-delivery. So this was about the first care bundle. The second one, which dealt with intelligent auscultation with graphic doctor, we wanted to assess the availability of equipment and the training and how the nurses are trained on intelligent auscultation. So we conducted interviews with the nurses. We directly observed them in the labor rooms to see how effectively FHR was auscultated according to the study protocol. And we also supplemented this with data from the project to see whether the FHR auscultations in terms of frequency, in terms of duration, were being actually conducted as envisioned in the protocol. Also, we wanted to identify, we wanted to see how the nurses were identifying the cases with alerts and prompts, and how promptly actually they were being able to identify this and escalate it to the clinical team. Thirdly, the electronic labor care guide, or the electronic partogram. Again, we wanted to see the availability of functional equipment in the study sites, and how the labor progress was being recorded, how each component of the labor progress was being recorded in the tablet. We wanted to look at labor induction and augmentation, as well as how the escalated cases were acted upon by the clinical team for proper management. And lastly, the brain-oriented neonatal resuscitation. We wanted to see whether there was an attending pediatrician at birth, which was one of the mandates in the study protocol, to ensure that immediate neonatal resuscitation was started. We also looked at whether delayed cord clamping and immediate skin-to-skin care were being practiced and to what extent. And for this, we interviewed the mothers in the postpartum period, as well as we looked at the project records to see to what extent, what was exactly the time to cord clamping. Following this, the early initiation of breastfeeding, which was another intervention. This also was looked at through direct observations as well as interviews. And lastly, maintaining therapeutic normothermia, for which the neonatal team was interviewed, as well as the project records were reviewed. So overall, the processes we adopted were direct observations in the antenatal clinic, in the labor rooms, in the postnatal ward and the neonatal wards, as well as interviews with the beneficiaries, which is the mothers and their birth companions, and also the clinical team and the team involved in the study, as well as reviewing the project records and the hospital records. Now coming to the results that we got from the quality audit. So I would like to discuss this under 3 broad headings. So firstly, the quality audit improved the implementation of the study. One example was the birth companion. So in order to motivate the mothers to actually have a birth companion during delivery and motivating the attendance of the mothers to be present during the duration of labor with the mother and helping her during labor. So after the first audit that we conducted, the study sites adopted birth companion champions, as well as they adopted the method of a general health education in the antenatal clinic OPD. So when the mothers were in the waiting area, every day there was a health education session which was being held as a part of the hospital health education program, where they're generally told about birth preparedness. So the birth companion component was included in that. So this was one of the ways. Secondly, early breastfeeding. So this was, it was seen from the first quality audit that very few mothers actually were able to start breastfeeding early within 30 minutes of birth. Following the first audit, lactation nurses and nurses who especially counseled the mothers on the importance of early breastfeeding, this was adopted. Thirdly, for neonatal resuscitation, so it was difficult for the pediatricians to always be present at the time, and it was a little delayed. Their arrival in the labor room was a little delayed. So an alarm system was actually adopted in the labor rooms, where any neonate with impending, we knew that the neonate would require resuscitation, the alarm system would alert the pediatricians and to be present. So all of these indicators, all of these domains in the second audit was found to be substantially improved. The second area would be the improvement in data validity. So this was twofold. So first was improvement in data capturing. So one of the things we wanted to ensure in the study was a recording of fetal heart rate at admission. So even though this was being recorded as a hospital protocol, but we were not being able to capture this as part of the study. So following the first audit, which found that FHR at admission was missing and it was increasingly difficult, there was an intervention where stamps specifically were given to the hospital, so that at admission or whenever the fetal heart rate was first being recorded, the FHR as well as the time of recording of FHR would be captured in the case sheet so that we could include it in the project data. Second was improved data completeness. So the electronic labor care guide, which is being operated by the nurses at the labor rooms. So here also it was found that the frequency and the duration of the FHR monitoring during labor, there was a lapse, there was a gap. So this was this feedback was given, following which we found that there was improved completeness of data, which is again an important aspect of the intervention of the care bundle. Thirdly, we found that quality audit also improved hospital practices as such. So from the quality audit data, we found a high use of oxytocin, which we gave feedback to the sites, and following which there were meetings which were held at the study sites for optimization of the use of oxytocin for induction and augmentation of labor. Secondly, immediate newborn care. So like I said, early initiation breastfeeding as well as delayed cord clamping was something which we found was not really being adopted. So following the trial, again, the hospital practices changed, and we found that most of the newborns, they had delayed cord clamping after the first audit. And thirdly, the audit also in general improved labor room quality, and which was, again, it was reported to us by the hospital management. So in brief, these were the three broad areas which our quality audit actually improved the processes. So the PREVENT study is right now in the second phase, the care bundle implementation phase, and we are going to integrate the findings from the quality audit and the process evaluation into the outcome evaluation, and to see whether it improves the trial outcomes. So in summary, the quality audit in research studies basically is to ensure the adherence to protocols, and we must keep in mind to include trial activities, any activity, not just restricted to the intervention. So any activity which could have causal links to the research outcomes. So fitting in the little details to the bigger picture. A good balance of qualitative methods and quantitative assessments with triangulation provides good audit results. Fourthly, patient and participant involvement is something which we should keep in mind. So not just restricting ourselves to the provider part, but also in order to really conduct a quality audit, we need to look at the reach of the intervention to the patients, to the study participants. So that is an important aspect. And finally, feedback, which is the most important aspect of the quality audit. So a feedback system, a feedback mechanism should be integrated into the quality audit mechanism. And so here I am going to end my talk, and I thank the organizers for this opportunity. Thank you. I'd be happy to take any questions.
Thank you very much, Dr. Rupsa, for an excellent wrap-up of the talk. And I have a question for Dr. Ian Roberts about, you started your presentation with saying that we should be giving Tranexamic acid at every planned surgery. Am I correct? So
Yes.
Could you just elaborate on that, please?
Yes. So I've been watching the tranexamic acid in surgery data for a long time, and there's now about 120,000 patients in randomized trials of tranexamic acid in surgery. And now I think there's proof beyond reasonable doubt that tranexamic acid reduces surgical bleeding. And there's absolutely no evidence that it increases the risk of vascular occlusive events. It's a highly cost-effective intervention to reduce bleeding. And I believe it's much safer than blood. I would rather have a gram of tranexamic acid prior to surgery than a blood transfusion. If I woke up after surgery, having received a blood transfusion anywhere in the world, and not had received tranexamic acid, I would feel really annoyed. So after there was this recent POISE 3 trial published in the New England Medical Journal about a month ago. And so I thought, right, this is enough, we have to do something. And so we've put together a group with representation from the Royal College of Surgeons in England, the Royal College of Anaesthetists, the Royal College of Physicians, Faculty of Public Health, and we're trying to implement the use of tranexamic acid in surgery. And I think the evidence is really strong. In low-income settings, it has extra advantages because the risk of transfusion-associated infection is higher in those settings. So it's something that should be a routine part of surgery, I really believe now. Yeah.
Yes, thank you for that comment. And also in low middle income countries, blood is very hard to get actually. So arrangement of blood is a nightmare.
Yeah.
Yes, Professor Shyam.
Yes, for the past 3 years, we have been using Tranexamic Acid routinely in our surgeries, in our teaching hospital as well.
Yeah.
So just tell Professor Ian that we have started using it quite extensively.
Thank you. So we have three very eminent gynecologists and obstetricians who've been our chairpersons and listening to this webinar very carefully. I will request them to give their comments, starting with Professor Farrukh Zaman. And I would request you to be brief as well, like 2 or 3 minutes. Professor Farrukh, you unmute. Yes, thank you.
Thank you, Professor Sadiah. First of all, congratulations to the Maternal and Perinatal Committee of SAFOG for organizing such an excellent webinar. Thanks to Professor Arul Kumaran for helping in devising and this nice program, which kind of encapsulates the whole of obstetrics, if I can say that. Starting with postpartum hemorrhage, which is a problem not only in developing countries, but it is a problem and it's a major cause of death in even the developed countries, postpartum hemorrhage. And the role of multi-center studies. I'd say that all 4 speakers, they made excellent presentations, and starting with Professor Luman, her study, which is ongoing, is that concerns with postpartum hemorrhage, and very rightly so, and in many of the underdeveloped countries. And I'm sure that the results would further corroborate and emphasize the good of bundle approach of management of postpartum hemorrhage. Professor Ian Robert, he has been championing use of tranexamic acid in surgery and in PPH particularly. I remember listening to him in 2011 in Dubai in one of the FIGO and WHO blood transfusion seminars, which I attended as a representative of FIGO. And he made a very strong case for using tranexamic acid at that time. The other 2 presentations, they related very much to good obstetrical care, importance of good antenatal care, and vigilant intrapartum care for our second patient, that is the baby. And the role of importance of multicentric studies and the audit of these studies, because the last comment which Dr. Banerjee made was quite important. She said that the important improvement in practices in the hospital practices was a result of this audit, which is very nice. So I'm sure that everyone would be taking along with them very good lessons from these 4 talks. And I would like to thank all the speakers for their excellent presentations. And finally, to the president of SAFOG for having organized this. Thank you very much.
Thank you, Professor Farrukh. Professor Shyam, would you like to say some words?
Yeah, I reiterate whatever Professor Farrukh Zaman has said. And I congratulate you for having got these eminent speakers to talk to us today. The hallmark of any obstetrical or any medical practice is the audits that follow the use of that particular implement. And it is important that we, as we have discussed today, prevention of PPH, the use of tranexamic acid, the improvement of health care or other maternity or obstetric care are all very, very important, because when you have multicentric trials being carried out, they tell us the use of the same but particular methodology in various situations in various countries. I congratulate everybody for having made an excellent talk, and Professor Arul Kumaran for having helped us formulate this particular program today.
Thank you. Our third chairperson, I can't. Dr. Sheela Mane, she's a senior member of our committee. So would you like to say a sum up, please? Yes?
Yeah. I think already Dr. Yan and Professor Shyam Desai has already iterated about this program. And I'm really happy to be a part of this session today, because there is so much of learning. And we, as we always say, that low income group, and particularly when I'm working in a public sector, I know that how important it is to implement all these things, because when the one-to-one care is not possible, but still, I think what Dr. Banerjee mentioned about the audit, which is definitely going to help us. And I think once the emotive study outcome will be known to all of us, I mean, it's a very large study, and which is very important, because the small steps in the beginning only, where we don't allow the patient to go into refractory PPH. Okay, so that is one great message, I think, and if that is implemented, definitely the PPH morbidity as well as mortality will come down. And then the tranexamic acid, yes, it is being used for the treatment, but I think as the Women 2 trial, we will be looking forward, as anemia is still a big problem for our country. Okay, even if we have Anemia Mukta Bharat Mohim right now going on, but still is a problem. I think we should be looking forward for that study too, which will definitely help us. And prevention of epilepsy. I think it's so touchy, that the simple steps are going to help to improve the overall health of the society. And that's a great initiative and a great study. And I think the implementation of this in public sector particularly will be of a great help, because as Dr. Sudhin mentioned about, it's not intranatal, but already if there is a morbid fetus or growth restriction, and a monitoring of the augmentation and the induction. That was a great message, because, just to deliver the patient in time, it may not be monitored, and we have to really see that what in future, how it is going to harm the future generation. So great messages by all the speakers. And I think it was a lot of learning. And I think these type of seminars and the symposium will definitely help all of us. And I would like to congratulate Professor Sadiah Ahsan for conducting this. And of course, I can say our guru, Professor Arul Kumaran, is here, and we always keep hearing from him about all this. So thank you all once again.
So thank you, Dr. Sheela. I will request Professor Arul Kumar. He's our guiding light at the moment. It was his idea that we should be doing this webinar. So Professor Arul Kumar, I would request you to speak now. Do you have any slides to share?
Thank you. No, I have no slides because I came here as a student, not to teach. So I would like to first thank all the eminent SAFOG members here, Professor Rashid, Latif Khan, Farrukh, Zaman, Shyam Desai, Sheela Mane, President Rohana, Ganesh, Dangal, and Preeti Kumar, and Sadiah for organizing this. First, I would like to say, I'll say things in three, so it's easy to remember. First, I was involved in the 3 trials, so I have a dubious honor of being a chair of the trial steering committee. I don't know whether I deserve that honor or not, but I learned as we go along. So Ian, thank you for the opportunity. Sudhin, thank you for the opportunity. And Arul Kumaran invited me to chair the trial steering committee. So I'm going to share the important information from the 3 trials, being chair of the trial steering committees. Number 1 is actually for a multi-center trial study, then you must have a trialist who has used to running trials, in calculating numbers, the power calculations, etc., etc. A statistician and the clinician. So it must be a combination of all these three. The second thing I want to remind you is that any trial, if it has to be done properly, there are three important committees you can construct for a multi-center study. One is actually a trial steering committee to see overall the trials are going well. The second is data safety monitoring committee. And third is the publication and dissemination committee. A small group should get together. Otherwise, there's no point running a trial if you can't do that. Just as a classic example, if you look at the emotive study, we were looking at the figures. The blood loss, although they were using draped sheets to collect, it was coming in rounded numbers, 50 ml, 80 ml, 100 ml, and in the mornings it's 200 ml, in the evening it's 500 ml. So it's a digit preference. So we had to implement saying verified data has to be sent. So not only the drapes had to collect the blood, but they should be on a weighing scale and the photographs should come with that. So you had to really implement some of the things to really do that. So I said the three committees. The next thing is actually to have three types of audit. Audit of the structure, audit of the process, and audit of the outcome. So any trial should consist that. And you heard from Rupsa, the audit of the process, structure, and if it is a care bundle, each care bundle should be subjected to those three elements so that it can be done. There's no point running a trial and saying, oh my God, we could have done this better, or that drug went out in time or something like that. So like she currently explained that there should be enough graphic Dopplers, infusion pumps, etc., the medication, and so on. And finally, I would like to say that it is always better to discuss things amongst your colleagues and the PI of each individual institution. So there are about 70 or 80 institutions. You must get a champion who can really walk on the board in the morning, afternoon, and evening. They don't have to go and verify things, but at least say, hey, how are you doing? How are things moving, and so on. Unless you have a champion to really see things, otherwise nothing moves. I have experience where I've gone to some trial sites in some studies and say, are you giving this medication? There, yeah, we give it. I said, okay, can I see where you store it? They asked the nurse, where is it stored? The nurse says, what are you talking about? We don't have that medication. So they are running a trial, but the medication is not there. So I think it's quite crucial. The local implementer should be a good champion, and also you should really have feedback and include all of them for discussion. So Sudin showed a picture of all the trial investigators. It's quite important that you should not only have the champion, but have regular meetings with the people with whom you are working. And not only at the champion level, but also the people who are really working, go to that institution and have some discussion. So that's all I had to say. And there's a lot more to say, but I know the time is up. So I would like to thank specifically Luma, Ian, and Sudin and Rupsa for presenting on a Sunday when you can watch Wimbledon tennis. Ian must be running to watch the game now. Thank you very much. And thanks a lot, Sadiah, for giving me this opportunity. Thank you.
Thank you, sir, for your giving us this time and all the people who were there. And I would now ask Dr. Professor Farhana Diwan. I'll try and introduce her quickly. But before I do that, we have our chief guests and honorable members, Professor Rashid Latif here and Professor Ganesh Dangal, if they want to quickly say something before if they have something to say. It's not in the program, but we could hear you as well. Yes, Professor Rashid.
Sadiah, just through you, I must congratulate Professor Rohana and the members of the committee for organizing this wonderful webinar, and I've learned a lot. As Sir Arul said, he was there as a student, so was I. Every time I listen to these webinars, I go wiser. So congratulations again, and keep it up. Thank you once again for inviting me to be part of this webinar. Thanks a lot.
Thank you. Professor Dangal, do you have anything to say?
I just like to congratulate you, Professor Sadiah, and the team there, and all the SAFOG leadership, and the presenter were very much useful, and we learned a lot, and we'll be looking forward several such programs in the future also. Thank you, everyone, and congratulations.
Thank you. So I will ask Professor Farhana to give the vote of thanks. She is the President-elect of OGSP, Deputy Secretary of SAFOG, Secretary General, sorry. She is Head of Department of Obs and Gynae at Ibn Sina Medical College. So Professor Farhana, would you go ahead?
Yes, Dr. Sadiah. First of all, I'd like to thank the Professor Rohana, Dr. Rohana, for giving me this opportunity, and of course Sadiah for having me here. And I know it is nobody has so much time to listen to my give me time to say thanks, but I think that I will do it in a nutshell and very quickly, because Dr. Rohana has always talked highly about me, and I really appreciate Sir's thinking about me all the time. He's mentioning me, but I enjoy working with SAFOG really. And I enjoyed all the papers. So first of all, before thanking anybody, I would like to thank the speakers, because they did justice to their topics. And I think that all of us are looking forward to the to June 2023, which comes with the emotive results, some results of the emotive trial, the Women's 2 trial, and I think the Prevent trial also. I don't remember the date of the Prevent trial, but I think it was there as well. So first of all, I would like to thank our honorable guest, Professor Rashid Latif Khan. It's really a treat to see Sir all the time. We have seen Sir all the time, and he's so much interested. And Professor Ganesh Dangal. I'm sorry I didn't see Professor T.H. Sir. Most probably he couldn't come. And the chairpersons, Professor Farrukh Zaman Sir, Professor Sham Desai, and Professor Sheela. They were also all the time with us, and they really, we are thankful to them. And Dr. Rohana was here as the president. I would like to thank Sir. And I've already mentioned about the speakers. So Professor Luman, Professor Ann Roberts, Professor Shudin Thal, Dr. Rupsa, and of course, Professor Arul Kumaran Sir. So last but not the least, Sadiah yourself, you made the program so lively, and it was really, really very wonderful. I think that each of us enjoyed the whole program, and it was really, I don't know how the time flew away. So I think that thanks everybody. Looking forward to another dissemination like this. Thank you very much.
Thank you very much. If there's anything anyone would like to say more, please go ahead. Otherwise, we will say Khuda Hafiz, good evening, good afternoon, good night. It's so wonderful to have colleagues from India, from Bangladesh, from Nepal, from UK, and many other parts of the world. So thanks to COVID, we have learned to use this technology. And it's brought us all together. And so unless anyone has anything particular to say, I think, yes, Professor Farrukh has something to say, and maybe Professor... No, enough on the Sunday. I think we all want to go home now. Thank you very much. Good night.
Thank you.
Thank you.